So with the 2016 definitions or change, what we wanted to do was separate infection from bad infection, where the patient has organ dysfunction, and septic shock, as Jean-Louis just said, represents a severe subset of this group of patients with organ dysfunction. And what we mean by definition, a definition, if you go to the dictionary, is what something is, the essence of something. And so that's the definition, a new definition. So we wanted sepsis to be life-threatening. We wanted the patient to have organ dysfunction as a result of a dysregulated host response. So it's not just systemic inflammation. There are many, many other things that are happening at the same time: metabolic, cardiovascular, anti-inflammatory, hormonal, etc.
Yeah, I had a little bit of a problem with this sentence with respect to the word life-threatening, and I raised the point with the group, because I was afraid that, and I'm still afraid, that people will call it sepsis only when the organ dysfunction is life-threatening. And so I'm afraid not to be called when a patient has a platelet count which is a bit low, because people may say this is not life-threatening. I'm afraid not to be called when the creatinine is a bit increased, because people may say this is not life-threatening, etc. So life-threatening may be too strong. I would actually personally prefer, but obviously the majority of the group did not agree with me, but I would personally prefer to drop life-threatening and say that sepsis is defined as organ dysfunction due to a dysregulated host response to an infection, because that's really what it is. And we still, as you said, Mervyn, we still want to be called early and not too late, and that's how people were concerned with our old new definitions. They were concerned about the fact that we may be called too late when a patient is in trouble or at risk.
No, again, just as we're talking about now, I made the point at the beginning, please do read the paper, because life-threatening, and we found, and I'll mention it later on, just a rise in SOFA score just of 2 points. So it's a relatively small rise, is associated, looking at these databases, with a risk of dying of 10%. So, 2 or more point rise gives you a 1 in 10 chance of dying, which I would argue life-threatening does encompass that. I 100% agree with Jean-Louis that you don't want to wait until the patient's moribund before the ICU gets called or we respond. So again, it's the use of the word. So the idea is that we just wanted to differentiate a straightforward infection where the patient's not likely to die from this more serious condition. And likewise with septic shock, again, what does it mean, shock? So we wanted to the patient needs to have circulatory problems and metabolic and cellular abnormalities, which are profound enough to substantially increase their mortality. So we wanted to differentiate this group from a standard group with sepsis alone.
Although here also I have a little bit of a problem, because I wouldn't like to define something by the increased mortality rate which is associated with it. Would you say that cancer with metastasis is a cancer, we call it with metastasis when there is increased mortality? No. So here also, I think septic shock is primarily characterized by the circulatory abnormalities that may be associated with cellular metabolic abnormalities, period. And of course, it's the most form of sepsis, as you said, and it is associated with higher mortality rate, but it's not part of the definition.
Yeah, but I'll challenge, well, no, I'll challenge you in reverse, because just as you say, if you take bowel cancer, on the grading, Duke's grading, the patients with metastatic spread have a higher grading and their prognosis is much worse. So yes, people without metastatic spread can still die, but your risk of dying is much greater if you've got metastatic spread. So I think
of course, and septic shock is associated with a higher mortality rate. But here you say is defined, are profound enough to substantially increase mortality.
Yeah.
It should not be part of the definition to say that the abnormalities must be profound enough to increase mortality. Shouldn't be part of the definition, but it's a consequence because we are speaking about something which is severe and therefore it is associated with higher mortality rate.
So the listening audience will appreciate we spent 2 years debating all of these issues, and you can see how it was always, as Jean-Louis I'm sure will agree, it was always very amicable. There was never any chairs thrown or punch-ups, but you can see we had lots of lively debate.
Although some people were obviously wrong.
Yeah, but a majority, clearly. So what do we mean by organ dysfunction? Here we wanted to use the SOFA score because, you know, that's been around 20 odd years, Jean-Louis. So
I think it was in 1996 that we developed it. So yeah, it's the 20th anniversary.
20th anniversary. And so looking at the data, a SOFA score change related to the infection of 2 or more characterizes organ dysfunction. And so does that mean you have to do 2 SOFA scores? Well, what we've said is no. If the patient is known to be healthy beforehand, you can assume the SOFA score is 0. If they're already an inpatient, you'll have the blood tests probably to know what their renal function's like and their liver function and their platelets. Or if they have chronic disease, it's likely that they'll be known about. So it won't apply to every patient. Some patients will fall through the gaps, but the majority of patients, we can pick this change in SOFA score. Jean-Louis.
I'd like to emphasize again or reiterate what we said earlier, because people looking at these recommendations very quickly now think, oh, so I must know the SOFA score by heart to know exactly when there is such an increase by at least 2. No, it's only for publications, and your computer system should actually do it automatically, but you do not need to know the SOFA score by heart. I don't know the SOFA score by heart myself, and I don't want. It's probably because I have a psychological block blockade. I just can't know the SOFA score by heart. And we should not know the SOFA score to identify sepsis. It's important because sepsis should be identified not only by ICU doctors, who may perhaps know these scores better than others, but it must be identified by other doctors, nurses, physiotherapists, and other people working in the hospital.
Yeah. No, I agree. You know, I'm don't walk around with the SOFA score in front of me. It's useful for, you know, coding, for epidemiology, for research, but in terms of patient management, you've got somebody who's obviously ill, you can deal with them. So sepsis, obviously, a lot of the time you don't make or confirm the presence of infection until 1, 2, 3 days later. So sometimes it's very obvious the patient has an infection when you first see them. Sometimes it may not be confirmed for a number of days. So again, sepsis is in many respects a retrospective diagnosis. Presumed sepsis, fair enough, but a firm diagnosis is often made as part of your hospital discharge diagnosis. You know, that once it becomes obvious what the patient actually has.
Well, the organ dysfunction is typically recognized quite easily and readily. Yeah. For the true infection that you can document on when you get all the results back from the lab and you see a little bit exactly. Whether alternative diagnosis could be maintained or should be ruled out, etc. So it's especially infection that that is sometimes identified a bit later, right?
Absolutely. So, pancreatitis is an obvious example where, until you get the amylase back or a CT or whatever, it could be sepsis, but it turns out to be pancreatitis. That's just to remind people about the SOFA score. They're routinely measured things, platelets, creatinine, urine output, bilirubin. So they're routinely measured. So you're not required to do things over and above your normal laboratory tests. Clearly, and Jean-Louis obviously, hopefully will agree, but it's not perfect by any means, but it's been around for a long time. The higher the SOFA score, the greater the risk of the patient dying. And so because of this familiarity and the validity in terms of prognostication, etc., that's why we choose to use this as a means of trying to standardize what we mean by organ dysfunction. Anything else?
Yeah. Perhaps a few words about the various items. First of all, it's important going from top to bottom, it's important to remind people that the Glasgow Coma Score should be the assumed score, i.e. the score that the patient would have in the absence of sedation. Too often people consider that sedated patients have a NeuroSOFA of 4 because they are comatose, but no, they should have a neurological score of 0 if they would have a Glasgow Coma Score of 15 without sedation. And for the respiratory score, you need some respiratory support to have a score of 3 or 4, but you may have some respiratory support and have a score of 0. If you are not hypoxemic during a surgical procedure, you have no respiratory failure, you are intubated and mechanically ventilated, but without respiratory failure. So you need the respiratory support to have a score of 3 or 4, but it's not the other way around. You may have respiratory support and have a low respiratory score. For the cardiovascular score, unfortunately, we had to introduce some therapeutic elements because there is no way around it. So we cannot just estimate it on the basis of blood pressure, because patients may have a normal blood pressure on high doses of norepinephrine, and so they are in severe shock. And lactate levels are not there because there is a time factor, and we did not want to introduce the lactate levels in these scores. For the renal score, yes, you need to have both creatinine and urine output, because patients may become anuric and yet their creatinine had no chance yet to rise. It may rise a bit later. For the hematological, only the platelet count, because PT and APTT may be influenced by therapy. And for the liver enzymes are not included because they may increase in any form of altered tissue perfusion. So ultimately, the bilirubin is perhaps the best test we could take, although it's far from very good. But clearly, in multiple organ failure, one often sees an isolated increase in bilirubin levels. And finally, we did not introduce a GI subscore because this is too difficult. How can you evaluate the GI function? You may say tolerance to feeding, but when we say how to evaluate it, it goes all over the place. We are not sure that we should measure the gastric residue, and if we do it, what would be the cutoff value? And likewise, diarrhea is difficult to assess, etc. So we gave up, and there is no GI component to the SOFA score.
Lovely. I'll crack on, but what I'd like to do is aim to try and finish within 10 minutes so that people can ask questions, because I see time is moving on. I mentioned about this infection and a rise of SOFA of 2 or more gives a risk of dying of 10%. Clearly, for the shock, and we went to data, I'll talk about that in a second, but we wanted a lactate above 2 and a requirement for vasopressors to get the blood pressure mean above 65 or above despite adequate fluid resuscitation. We agreed that we couldn't give a clear meaning to what adequate means, so that, you know, there's no clear, obvious answer. So it depends on how you do it in your hospital. You have to decide what adequate means. But if the lactate is still high and you need to give vasopressors to get the blood pressure above 65, then that characterizes shock. If you can't measure lactate, then we suggest perhaps use other markers of poor perfusion like capillary refill, but ideally that needs lots of prospective work to make sure that there's good validity to that marker. Jean-Louis.
So I agree with you. It's just impossible to define adequate fluid resuscitation. We have been criticized in the Surviving Sepsis campaign for the same thing, but it is just impossible. You know, the response to fluid challenge would be the best way to evaluate it, but people may do it in different ways, and so we cannot be more precise. With respect to the definition, some people say, "Oh, now you come up with something new." No, you know, this has been the definition of shock for decades, and in our New England Review article, that's exactly what we say. It's altered tissue perfusion associated with some degree of hypotension and a lactate level above 2 millimole per liter or milliequivalent per liter, whatever you prefer. But so there is nothing new there. And personally, I don't like your nota bene, if you can't measure lactate, use marker of poor perfusion.
Yeah.
Because we should always use a marker of poor perfusion.
But it's just if you're in the middle of Africa.
Pardon? Sorry?
If you're in the middle of Africa, for example.
Yeah. So you do without lactate, period. And because it's important to evaluate the urine output, the capillary refill, and the mental status, the three windows of circulatory failure, as we wrote in this New England Journal article. So that's part of the basic clinical evaluation. And we should not say that we need to look at capillary refill only when we can't measure lactate. No, we need to do it in all cases. But I think that our criteria here will support the use of lactate levels everywhere in the world. And indeed, in poorer parts of the world, they could actually use these recommendations to support their request for a blood gas analyzer with lactate analysis. It's relatively cheap today to measure lactate levels. It should be available everywhere, exactly as glucose or sodium or potassium levels should be available everywhere. It's not more complicated than that, and hopefully it will be generalized in the next future. It shouldn't be a big problem.
Yeah, I agree with you. Why didn't we use lactate or hypotension? People have said, why do we need both? Again, this point about increasing mortality, we went to the Surviving Sepsis Campaign database, which is an international database from memory of about 30 countries. And we looked at nearly 30,000 patients who fulfilled the old criteria of 2 or more SIRS, 1 or more organ dysfunction after fluid resuscitation. And as you'll see, the mortality was actually, interestingly, very similar between patients with a high lactate alone, a low blood pressure alone, or organ dysfunction without a high lactate or a low blood pressure. It was only when you put the two together, a hypotension and a lactate of above 2, you got a 42% mortality. If you made the lactate above 4, you halved the number of patients, but the mortality now went to about 55%. So the combination was associated with a much higher risk of dying.
Well, yeah, you may go back. I have no problem with what you said, but in terms of principles here, we are not trying to find a subset with the highest mortality, are we? Because otherwise, And actually, I reviewed a paper on this. Now people, say, oh, if we add this, if we add that, we have a higher mortality rate. But of course, just add the H and you will have a higher mortality rate. Add oliguria. So you could define shock by all this plus oliguria, and you will have a higher mortality rate. But that's not part of the game. I think shock is a pathophysiological entity, which is indeed the altered tissue perfusion. So it makes sense to take both the hemodynamic evaluation with hypotension and the 3 altered windows of tissue perfusion, and the high lactate level that basically reflect the abnormal oxygen metabolism in the cell. So the aim of the game is not to find a subset with the highest mortality, but rather to find something that makes sense. And that, to me, that's the basis for all these discussions. We must have, the definitions that must make sense for doctors and the healthcare practitioners.
Yeah, no, I totally agree with you. It's about making sense. The point I just add, like the 3 early goal-directed therapy studies that came out last year in the New England Journal, basically they were working on mortalities of around 35 to 40%. However, only 15%, 15 to 20% of the patients had both hypotension and a high lactate. So therefore, the majority of patients fell in this lower risk group. So again, it helps to just get people talking the same language.
Yeah.
Likewise, what does lactate mean? The lactate in the emergency room, these are the 3 studies I've just referred to, the early goal-directed studies, and these are some ICU septic shock studies. The mortality was much higher in the ICU studies, but the lactate on a baseline before entry into the trial was a lot lower. And so lactate means different things in different places. It's a marker of unwellness, but often it's a marker of a severe stress, in my opinion, which obviously is manifest differently in the emergency room to the ICU. Quickly, we'll go on to Q-SOFA, and I think Jean-Louis and I agree very much. It's a bedside stratification tool. It's not a diagnostic for sepsis. So again, looking at the data, Chris Seymour looked at 21 routinely measured things on the ward: heart rate, lactate, blood pressure, etc., and found these 3 things came out the strongest in being prognosticators. A low blood pressure, altered mentation. Initially, it was on a Glasgow coma score of 13 or below, but when he looked at 14 or below, in other words, any abnormal mentation, there wasn't much difference. And so to make it easier, we've just stuck with that, and tachypnea 22 or above. So these represent possible cardiovascular dysfunction, possible neurological dysfunction, possible respiratory and or metabolic dysfunction. And the risk of dying was much higher with the more of these criteria. So again, it doesn't mean you should ignore patients who are ill you're worried about just because they don't have any of these 3 criteria, but it's just a stratification tool. The patients who have 2 or 3 of the Q-SOFA criteria are much more likely to end up dying.
Yeah, well, to me, it's more an alarm signal, and primarily for our nurses, because you can get this information very easily. You don't need any blood tests of any kind. It's just at the bedside that you can identify these problems, and they should actually, ring a bell or put off a red light telling you that the patient may need more attention.
Yeah, agreed. Just to say, again, how do you use SOFA? Q-SOFA, rather. Again, depends on your country, what system you operate in your hospital. In the UK, we have this National Early Warning Score. There are 7 criteria, and interestingly, the QSOFA criteria, any altered mentation, respiratory rate, blood pressure, you score points. And in the UK, if the score in total from all 7 comes to 4, or in some hospitals 5, the nurse calls the doctor. So we're saying prospectively validate QSOFA in your hospital setting and see how it works. Does it add anything over and above what you're currently doing? If you remember from the beginning of the webinar, this was based on American data, retrospectively analysed, so we really do need the prospective validation studies. So,
yeah, I'm not sure that we need such a score, but that's another story. Yeah.
Okay. So yes, SIRS is important in helping you make a diagnosis of infection. You may not want to give them antibiotics. Doing QSOFA is much quicker to do. You know, you can do it in 2 minutes at the bedside. You don't need, like for SIRS, to measure the white count or the carbon dioxide, but you don't need SIRS for the diagnosis of sepsis. For lactate, again, people like lactate for guiding their management, but we were concentrating on definitions and criteria to support the definitions. You don't need it for sepsis, but you do need it for septic shock, as it's readily available by and large, and it's the best marker we have, although not perfect, for this cellular metabolic stress.
So this is important. Lactate is not a sepsis marker. I've heard some authorities, saying lactate is a sepsis marker. No, it's a marker of shock, as you indicate. So in cardiogenic shock, lactate levels go up. In hemorrhagic shock, lactate levels go up. In obstructive shock, like in massive pulmonary embolism, lactate levels go up. So it's not a sign of sepsis.
Yeah, and there's some recent studies showing that the prognostication of lactate isn't as strong as some people claim. Just quickly, last couple of minutes, what QSOFA isn't, again, we've made this point, it's not an absolute diagnostic. It's a tool, a prompt to make you think, do I need to worry about the patient? Do I need to escalate their level of care? Do the blood test to look for organ dysfunction, etc. Agree, Jean-Louis?
Yes, but I think we are reaching the end of our webinar here, if you want to say.
Yeah, so basically, don't wait until they get to QSOFA of 2. If you're worried, start treating them. If you think they need antibiotics for an infection, treat them. If they're oliguric or they're, that should be hypoxemia, then start treating them. So we've said in the paper, if they've got 2 or more QSOFA, you definitely need to look for organ dysfunction. On the other hand, if they don't and you're still worried, you should still take them seriously. Pediatrics, again, there are initiatives underway to derive clinical criteria for children at different ages. What about low and middle income countries who may not be able to do the blood test readily? And again, we need the prospective studies to look at, for example, is QSOFA useful? But at the moment, we want to see the studies rather than making firm recommendations. And again, that's what next. Again, please look at it in your healthcare setting. Eventually, we can look at SOFA, and then we can better look at comparisons around the world of incidence and mortality, because we're talking the same language. So it's not the final word. There will be a new set of definitions and criteria, hopefully, when we understand more about sepsis. Maybe there'll be the perfect biomarker, but again, that's for the future. But we hope the work we've done now is one step forward.
Very good. Thank you very much, Melvin. I think our time is up. Yeah. I have another meeting, by the way. But on behalf of the World Federation, many thanks to you, many thanks to Phil, and of course, many thanks to our participants. Have a great day, afternoon, night, whatever. But we will certainly continue these webinars on other topics. Many thanks to all. Bye-bye.
Thank you very much indeed.
Thank you.
Bye-bye.